Hi, my name is Rebecca Fitzgerald. I'm Professor of Cancer Prevention at the University of Cambridge. I'm an honorary consultant in gastroenterology, and I'm currently interim director at the MRC Cancer Unit. I always wanted to do medicine from when I was very young, actually about 4, apparently. I declared that interest and clung on to that and all the way through my school, and then applied to medicine. And I read medicine at Girton College in Cambridge. And then I qualified and continued my early jobs, then called house jobs, and senior house jobs here in Cambridge and in this deanery, so nearby hospitals. And at that stage, I wasn't particularly heading for an academic career. And the MB-PhD program, I think the very first person to do an MB-PhD in Cambridge was actually somebody in my year, but no one else knew about it. It was kind of designed for her. And I was intrigued by that, but even if that had been on offer, I don't think I'd have done it at that stage. And then I was interested in doing research at some point. I wasn't sure about it. And I think flexibility in careers can be important, and not everyone knows what they want to do early on. And I would be a case in point. So my husband got a job at Stanford, an academic job in engineering in the US. And I thought that was going to be a bit tricky for me because I hadn't got my US exams to enable me to practice in medicine. I was at just the point of choosing my specialization, and I was very interested in gastroenterology because I'd had exposure during my training as a student and a junior doctor. And I was also interested in cancer medicine. But I'd also was quite struck by how poorly some of the patients did that I was looking after, particularly with ovarian cancer. I wasn't sure if I could hack oncology as a career. So I was kind of at a bit of a crossroads thinking, which specialty should I go into? Should I do a bit of research at some point, and how was I going to get on in the US? And I decided that perhaps the US would be a good time to pursue some initial research. So I talked to various people in the Bay Area in California, where my husband was going to be based, and met somebody there called Professor George Tridophilopoulos, who was a very inspiring gastroenterologist who was mainly clinical, but worked on the precancerous condition Barrett's esophagus. And I thought this could be great because it could combine my clinical interests in gastroenterology and cancer with doing some research. And so that's how I kind of got set on doing initial research, which was more kind of a bit of serendipity and convenience, if you like, rather than at that point I was really destined to do clinical academia. So I got some grant monies and I started that research at Stanford, and I found that I really quite enjoyed it. I found it really interesting to be pursuing a focused research question and making new discoveries. I also did miss the clinical medicine. And so it became clear to me that some kind of hybrid would be really the way to go. After pursuing that period of research, then I got back to the UK and pursued my specialist training, and decided at that point that gastroenterology was probably going to be for me. I did actually look into doing dual training in gastroenterology and oncology, but was told that I had to do one and then the other afterwards and double the length of training. I wasn't sure about that. So I decided to train in clinical gastroenterology and continue research. So came back to London, to Barts in the London, applied for further research money, got an MRC clinician scientist, and then in sort of early 2000s moved back to Cambridge just to complete my clinical training, get my CCST, and then start to form my independent research group. So the move to clinical academia came kind of gradually for me, but as I realized more and more that was what really, for me, was the best of both worlds, and was very inspiring and fulfilling. Early on, I think the choices were quite difficult in terms of deciding how much time to spend doing clinical medicine, whether to do training in general medicine, which I did do, as well as specialty, as well as doing research, and having the courage to do more research which is very, obviously competitive, and worry that, would I then, if I had needed to go back to clinical, would I still have that option open? Would I ensure that I maintain my skills? So I think that was kind of an early set of challenges. Another one has been really you want to be an excellent clinician in whatever you do, but obviously if you're doing less clinical to do more research, then you can't do everything. And so what I ended up doing was narrowing down the focus of my clinical work to the areas which I was most interested in and becoming expert in, whilst recognizing that I couldn't do general gastroenterology, and my focus has been on esophageal cancer. And so, for example, I did much less hepatology early on, and then later on I did became even more focused and did less work on inflammatory bowel disease, for example. So forming a clinical niche that I really felt confident in, I think was another challenge. Time management, I'm sure all clinical academics would say this is a challenge, because you're trying to do clinical work and you're trying to do research. Inevitably, there's some teaching in with that as well. And so, you have to be quite disciplined to protect the time that you need to do clinical and research. And obviously, patients will always demand all of your, as much time as you will give it. And so to keep the clinical time kind of separate from the research can require quite a lot of discipline, because no one's going to ring you up or, hassle you about not finishing the research. That's much more down to you driving that forward. The other challenge, especially when I was starting out as an early career researcher, was trying to have a family and balance then all of the work. So I have got 4 children, and I'd always wanted a big family, and that's been a great joy for me. But it also obviously added extra challenges in trying to manage that and travel, particularly, which is part of doing academic research. Now I've got more management responsibilities, and so trying to leave time for research amongst administration, and mentoring new clinical academics, early clinical academics is something I'm very keen to do, but all these things take up time. So again, it's about then how you balance the different responsibilities. Being really expert in something and forging a new path, so making new discoveries. And for me, my research is very applied research, so actually doing things that I think could benefit patients and change the way that we practice medicine. And for me, that is what's been very exciting. The kind of research I do, so I've been developing a new diagnostic test for early detection of esophageal cancer, and that's brought me into contact with all sorts of experts across different disciplines. So I've worked with colleagues, for example, in engineering, in maths and physics, machine learning, public health, health economics, clinical trials design, and so on. So a really, a host of different people, and that's been really exciting. As a clinical researcher, you do, although the time management I said is a challenge, you do have a lot of control over your time. So it is up to you to divide that time up, to work more flexibly if you want to have fantastic opportunities to travel, meet other researchers around the world. So I think that's both a great opportunity as well as a bit of a challenge. I mean, early on, I was interested to really understand why it is that Barrett's esophagus, this precancerous condition, can in some patients lead to cancer. What are the triggers? What are the steps? And dissecting that out at a cell and genetic level. And the more I got into that, the more I kind of also appreciated the real clinical bottlenecks, the things that were really proving to be obstacles to improving patient outcomes from this cancer. And the thing that I came back to over and over again was that we need to be diagnosing these patients earlier. So I set about developing what's now called the Cytosponge TFF3 test, which is a cell collection device, very, very simple device, a little pill on a string that you swallow, and then developing a series of laboratory tests to go with that device that would both diagnose the Barrett's and predict who would develop cancer. And to do that has led me into a lot of genomics, a lot of biomarker work, immunohistochemistry techniques, and also large clinical trials in primary and secondary care. I'm always really impressed and delighted about how willing patients are to take part in research, especially when it's early stage research. So early on, for example, in the cytosponge journey, we were asking patients to try a brand new device. We didn't really know how good it would be. There wasn't going to be any benefit for the patient themselves at that stage. And yet people were remarkably willing to try something new. We spend a lot of time with patients when they take part in research, build up relationships. And I think there's a real mutual respect for the benefits that the patient is giving to the researcher, and that we're giving to the patient. So I think it's a really fantastic opportunity. And of course, we couldn't do the kind of research that I do without the participation of patients. And they've taught me a lot as well about what the important aspects are for early diagnosis in particular, but what the characteristics of a test need to be and a device for it to be acceptable, feasible, and so on. I think believe in yourself and persevere would be my two buzzwords. So I think sometimes, maybe you've been passionate about doing research from very early on, or maybe you thought I won't be good enough. I'm not sure that I've got what it takes. It seems too uncertain in terms of the funding landscape and so on. I think these kind of doubts are absolutely natural and right questions to ask, but give it a try, and you may well surprise yourself with what you can do. Academic research is full of ups and downs, as in any job. Any job in medicine will have those real high moments and things that are frustrating and difficult, and research is no different. And there will be knocks along the way when your paper doesn't get accepted, when you don't get the grant that you want, when things are just going slower than you had hoped. But if you've got a good idea and something that's important, perseverance is the key to making progress. Probably that you need to be a genius and not sleep at night, because you have to spend 24 hours a day to fit it all in. I think clinical academic research is hugely broad church. I actually think that, and the NHS was actually conceived on the idea that all of the people in the NHS would be contributing to a research culture to benefit patients. And I think all of us should be trying to improve the way we do things and contribute to research in some shape or form. And that maybe you devote most of your career, or it may be that you facilitate. So I think it's not something that should be terribly unusual or a strange breed, or means that you can't hack the medicine. I think it's a fantastic career, and more of us should be doing it.